Welcome everybody to our momentum discussion. This is a long-term care and infection control, doing it differently. These are on topics selected that are experiencing momentum in the field of gerontology. There are handouts with biographies and suggested references. This program will run about 60 minutes, and you'll hear a conversation between us as a group of panelists. The two panelists with me are Carolyn Blackman and Ed Davidson. Carolyn, could you just say a few words about yourself?
Absolutely. Thank you, Stefan. I'm Dr. Carolyn Blackman. I'm an internist by training. I'm Senior Vice President of Medical Affairs for Genesis Healthcare, Genesis Physician Services for the Northeast region.
And Ed?
Thanks, Stefan. Hello, I'm Ed Davidson. I'm a partner with a research and education firm in Norfolk, Virginia called Insight Therapeutics, and I hold a faculty appointment at Eastern Virginia Medical School in the Department of Internal Medicine and Geriatrics.
Thank you, and I'm Stefan Grabenstein. I'm a professor at Brown University in the Division of Geriatrics and Palliative Medicine. Thanks for joining me today. As you know, COVID-19 has really taught us a lot about infection control in the long-term care facilities. And our goal today is to sort of talk about what those lessons are. And I think a good place to start is just sort of reflecting on what makes a facility particularly prone to or protected from outbreaks. Either of you want to tackle that?
I'm happy to start.
Go for it.
Long-term care facilities are particularly prone to outbreaks because of the sheer number of people that are living inside of them, and also the sheer number of people that are working 3 shifts a day, staffing them in many, many capacities. So it's not just our nursing staff, it's also CNA staff providing close care and assisting with activities of daily living, dietary, housekeeping, activities directors, to speak nothing of the medical staff. It is a high human touch industry inside of our facilities every single day, every single shift. So that would be right at the top of the list. Ed, do you have something to add to that?
Yeah, I mean, from a person level perspective, the individuals living in the nursing home, their house, their home, are particularly fragile. And they have oftentimes have multiple medical conditions, and they take a lot of medications that increase their risk for infection.
Yeah, and one other feature of nursing homes is a fair proportion of the population has cognitive deficiency. And there's a relationship between having a disorder that's in the dementia-related disorders category and the risk of having outbreaks. And I think that's multifactorial. One part of this has to do with the folks who are cognitively impaired have a harder time, complying with distancing, wearing PPE, and so forth. And a second thing is they have a higher caregiver burden. So they have more direct contact with staff who can often serve as vectors and introduce the disease. I think the long-term care setting has one other feature that relates to staff, and I don't know if either of you want to comment about this, but there is just incredible staff turnover, and that problem with staff stability increases the use of part-time workers. And part-time workers often work in more than one facility. And that means that the opportunity, if there's an outbreak in one facility, for it to go to another facility through these part-time workers is another particular risk.
I'd like to add one more risk in addition to that. I think nursing homes and long-term care facilities are really a part of the community, and the community is really a part of what makes them tick. There's a lot of people, a lot of family members, a lot of loved ones, and a lot of volunteers that contribute to the comings and goings and the care of people and the activities that happen inside of them. So that's a whole other population that we hadn't named.
Right. So how what have you learned about how to manage just the visitors? What's being done out there? Carolyn, why don't you tackle that?
Well, I'm not sure. We all know, as a nation, we know that what we did at the outset of the pandemic was to halt visitation. And that brewed a second set of problems in terms of separation and confusion. And we will all have to take some time on how we look back on that moment. But that was one of our efforts to reduce the amount of exposure.
Right, and the consequences of that isolation on the health and well-being, separate from the direct risk from infection.
Absolutely.
Yes.
And Ed, what about using antimicrobials?
Well, I mean, in spite of the pandemic, people still got infections like they normally did, often related to the respiratory tract, urinary tract, or skin and soft tissue infections. So, I mean, antibiotics and antimicrobials that include a broader range of things to treat other things are commonly used. And so outside of viral infections, they do contribute to the burden of infection in the nursing home. Specifically with regard to viruses, unfortunately, when the pandemic started, we didn't have any effective treatments, and we didn't have a vaccine available. So that really put us in a position of unique compromise that we hadn't been exposed to for maybe 100 years.
One other feature I think that we learned was that, sort of how you pull the trigger on an antibiotic and how you try to reduce the number of med passes and things, because then you have trying to gate how often people go into the room. I think it's changed a bunch of other things. I know that Dr. Blackman has some experience from that in their system, and sort of the lessons about all the medications we use and whether there's a way to do stewardship of medications in general.
We definitely did. We were very thoughtful, very conscientious about trying to reduce the number of med passes and be more efficient about the number of times that the nursing staff went in and out of every single room. And it gave us all an opportunity to accomplish another long-term goal, which had to do with deprescribing, which is critical in our industry, but not necessarily no one had thought of in terms of an infection prevention strategy before.
Yeah, COVID has proven to be so contagious that I think we had to sort of rethink what our best practices were and how we executed them. It's really quite different now. So when you know this is coming now, you have this pandemic wave coming at you. How do we prepare differently? I think I'm going to aim that at you, Carolyn, again. So what do we do differently at the front end to get ready?
No single answer, right? Right?
Yeah.
I'm sure Steph is laughing. No single answer. So, of course, we would now know right up front. We would be very, very thoughtful about our staffing. We learned very quickly that trying not to share staff from unit to unit was important. We learned to be, and that went for everyone, right? It went for thinking through the medical staff who often attend in more than one center, and being thoughtful about how they move around in a community so that the medical staff themselves were not the carriers or the vectors of the virus moving around. That would be also on the list.
So you're referring to platooning, right?
Sure.
That's what we called it here, is you try to constrain, so the people that were going to the nursing homes weren't also going to the hospital. And if they were normally assigned to 3 nursing homes, we try to divide it up so hopefully they go to as few nursing homes as possible.
Agreed.
The nurse practitioners, the doctors, whoever it is, that was on our group.
Yeah, just one more thought. I think one thing that the pandemic changed for the future is the use of information about the epidemiology of the infection. and how it was moving and where it was moving and how much burden we had in various parts of the country that helped us assess our risk and potentially, change our behavior and our procedures and so forth to be more prepared. And I think that's, change things, forever in terms of information management.
Another aspect has to do with, we talked about visitors, but we didn't talk about the people who have contracted services that come into the facility that are also much like visitors, and how we had to change criteria about how we let them in, and now more recently vaccination status and masking and so forth.
Oh, we opened up all new levels of conversation about essential workers, right? Because, shall we go back to the discussion we all had about hairdressers? Right?
Yeah. Certainly there's now, quite a few outbreaks where the hairdresser was the vector.
Yeah.
But they were important. We needed to get them back.
Yeah, we needed lipstick and hairdressers. That's right.
Well, and when pharmacies delivered medications to the nursing home, normally they had procedures of accountability control in place where they went to the nursing unit where the med cart was, and they went to a procedure of documenting the inventory and so forth, because often we're delivering things like controlled substances. But those had to change to be more or less leaving things at the doorstep and then standing back and watching someone, do inventory and control.
How did ventilation and cleaning practices change? So one thing that I think I learned in this was that, like in public schools, the air handling systems were designed to turn on and off to save energy. And the problem is when they turn off, then the clock starts for how much time you're spending face to face and your exposure risk. So changing those DCO systems into always on was an energy sacrifice, but also was presumed to reduce risk of transmission. And spraying stuff in the air to sort of ionize the air and trap particles and get them to stick to surfaces so that you couldn't inhale them. Ed, do you know about in the facilities where you are?
Yeah, I can. In the office setting where our research activity is, the building, put in new filters, but they didn't put in medical grade biologic trapping HEPA type filters. They just put in new filters that filter more stuff, but not the stuff we're necessarily interested in. And unfortunately, a lot of the nursing homes in our area didn't have the resources to put in those systems either. So they just more or less did better at what they normally did with regard to filtration. But there weren't dramatic changes in the way they did things. Hospitals, that's a different story. They pulled out all the guns to use all of the robotic sterilization systems and so forth, but nursing homes, not so much.
Right. So the number of air exchanges are things that are being monitored now in some schools. Certainly in New York, and now the UK is looking at that as a way to think about this. And another way to do it is by monitoring CO2 levels. So when there isn't enough air exchange, those CO2 levels start rising, and it tells you that you're not handling the air, not exchanging it often enough, whether or not it goes through a filtration system. And opening windows, which I think will be a new, interesting addition for the coming winter season. In the summer, it was also a problem. So in places that are particularly hot, like in Florida, you saw, I think, as people went indoors for air conditioning, they weren't getting fresh air in because they were recycling the same air and energy savings. And I think that had an effect on outbreak risk and spreading things within the buildings. So I think the consequence was that in nursing homes we experienced the highest mortality of any particular group in the country. And healthcare workers in nursing homes also had excess mortality, the highest risk occupation, after folks who cut down trees. And And really, the only thing that turned the tide for us was the advent of vaccination. But I think we learned a lot about vaccination, too. Again, Carolyn, you guys had some aggressive programs for trying to figure out how to improve vaccine uptake. Can you say something about that?
We did, and remembering that skilled nursing facilities were federal pharmacy partnership, federal vaccine rollout phase 1A, right? So the vaccine, the Pfizer vaccine, got its approval in December of 2020, and we began our vaccination clinics right then at the end of December. We really worked hard at it. We really did. We did some extraordinary Ask a Doc sessions and reach outs to every center to really make sure that we could answer staff questions as comprehensively as we had information for right at the time. And it was very, very close, small groups to one provider right from the get-go. Any question. We had slide decks and some handouts and all kinds of things. And that continued right on through March as we went through the second round of vaccines and offered at the second vaccine clinics people to get their first shot, and followed up to make sure people who were discharged had an opportunity to come back and get their shots. Yeah, it was really very much an all hands on deck, leaning on our medical directors, our nurse practitioners, our physician's assistants, our attendings, everyone was in to do teaching.
Yeah. And I think for the first time ever, the operation leveraged the role of the pharmacist in giving vaccines through their partners at CVS, Omnicare, and Walgreens to help, add to the effort of getting individuals vaccinated in the setting and getting their vaccination documented into systems. And if I could, at the same time that the effort that Carolyn shared about Genesis, there was a research study that was implemented called Impact C that was coordinated by Brown and Harvard University in collaboration with a group of nursing home chains, a small group of facilities from Genesis, and 3 other chains, where we looked at an intervention to try to educate nursing home staff about the value of the vaccine and to address their concerns through town hall meetings with physicians and geriatricians, and who answered their questions in an extremely thoughtful way to try to inform them the best they could, to accept the vaccine.
Yeah, and I think from your intervention, Carolyn, not asking a statistical question here, but my impression was that the people who got the first exposure to those talk to the doc sessions also seemed to have higher uptake in that first round in the clinics.
Possibly, for certain. We had other campaigns that were going on. Now that I'm thinking about it, we had slide decks of people actually getting the vaccine and explaining snippets, like headlines of who they were getting vaccinated for. That was a big part of our weekly communication, our weekly call. I took my shot. I took my shot for this person or for this reason. We really tried to identify what people were hesitant about and make sure that we spoke directly to those things, whatever it was. We can go back, there was concerns about cultural concerns, there were fertility concerns. It's hard to go back all the way to January of 2020 and think about what we were talking about then. Those people who had the disease and didn't know whether to get vaccinated or not, remember? But we really tried to address it issue by issue and answer people's questions directly.
Yeah, and Ed, in the Impact C work, as I recall, you guys were also trying to find champions.
Yep.
We did. We tried to leverage community champions that were identified by the leadership of individual nursing homes. But we also identified nationally known champions that had made public statements about those, and we, pushed those out through social media outlets that a lot of nursing home staff use to try to, just engage them with opinions from people that they respect.
Yeah, the GSA's National Vaccination for Adults program had developed a course to sort of train champions for health systems. And so this was a miniature version of this that done sort of in real time as you guys were trying to put these things in place in both Genesis, but also in the Impact C component of this. And it's always striking to me that the frontline staff, the less education they have, and this may not be a fair statement, so you can call me on that, but it seems to me that the less education they have, the more likely they're going to rely as their authority as somebody that they like and trust, as opposed to necessarily somebody that has the knowledge and skills to be able to talk about this in an authoritative, in a knowledgeable way. And I think these doc-on-doc sessions and designing, picking champions and training them, I think was trying to shift that conversation to who they were going to for that authority to make those people accessible so they themselves would then become an authority. I think that's, to me, that's the cognitive therapy of improving vaccine uptake. When we talk about this, so how do we apply this to flu vaccine, for example? What did we learn about getting vaccines in and what will work for a flu vaccine, or when the COVID vaccine becomes a seasonal vaccine, which I expect will happen next year? Are we going to do the same thing? That was a lot of effort.
Yeah, well, I was on the Virginia task force, long-term care task force for COVID. And we had our meeting a couple of weeks ago, and it was striking to me that the COVID vaccination rate among staff is now higher than the influenza vaccination rate. And I think that's very telling for the amount of work that we need to do, with using these same techniques to increase that uptake.
Do you think that's mandate driven, or is that driven because of education and, is it guilt? I don't know. What gets people to get a vaccine for COVID and not flu?
I don't know. Carolyn, I thought influenza vaccine was kind of a mandatory procedure for nursing home staff, but it doesn't seem to be adhered to very well.
Carolyn, insights?
It seems like so long ago. They had the choice. I know it's hard to talk about, hard to think about. Influenza vaccinations pre-COVID, the staff always had the opportunity to get their influenza vaccine, and if they didn't, they would wear a mask.
Yeah.
During flu season, and some people chose that, and it wasn't a big deal. Mm-hmm. But yeah. I don't know how, Stefan, what do you think going forward with the seasonal COVID vaccinations?
Yeah, I have my solution is the distasteful one, where I think healthcare workers have an obligation to their patients, and they should do everything they could to keep from being vectors of disease. And so masks, not just for flu, but for RSV and other kinds of things, are among the things that you can think about that you could do. Clearly, when we went into this lockdown state in this past year, influenza, RSV, these other respiratory and contagious infections pretty much disappeared in the long-term care setting. And now in the summer, as people have started letting their guard down, they're starting to reappear. Who knows what the flu season brings this year. But I think, there's so much COVID fatigue When you look at on television, the people that show up in the stadiums, all of them unmasked. Or if you go to a restaurant and it looks like COVID never happened. To me is this idea that, the cynical idea that we won't be able to do what we need to do to succeed in this way again unless we have another bad pandemic like this, or we mandate vaccines as not a good idea but a requirement to be able to work in healthcare settings face-to-face with patients. If our attitude about this were to change, so it becomes something that's required as opposed to a good idea, and then I think people get to choose at the time they get their education whether they even want that education, if they want people telling them what vaccines they should get or shouldn't get and so forth. It's hard to do when you have lots of folks that have already invested all this time and they didn't know that that was part of the price to play. But I think we have to make it part of the price to play, either now or as an expectation that's going to grow with incoming students. So, sort of along the same lines, we have, I think, ample data to say that there's a difference in quality of vaccines out there. So with a regular flu vaccine versus these enhanced flu vaccines, clearly reduce hospitalization risk and other kinds of things. But the majority of facilities in the country still use just a regular vaccine. What are we doing wrong?
I think we've probably fallen a little bit short in terms of educating the provider base on the differences between the vaccines, the differences in their efficacy and effectiveness. We have effectiveness data now on the vaccines. They're excellent safety profiles, and so. The other thing that, right, it's such a common procedure. The decision-making is on the purchasing level. I need flu vaccine, just find the cheapest one I can get, and that's what we'll get. And I think there's some value propositions that just aren't being discussed about the different vaccines.
Yeah, so is it because facilities have decided not to bill for the vaccines and therefore are carrying the cost to reduce the administrative burden and therefore aim for price over effectiveness?
So I think some nursing homes, and Carolyn, please weigh in on this. I think Genesis might be different because they've got a lot of corporate support and so forth. But just for the average nursing home, they will just purchase the vaccine and not think about billing for it, individually or documenting administration, just because it's easier. If they don't spend a lot of money, they can just do their vaccine campaign and move on to their next infection control task. They see it as something they have to do generally by around the 1st of October for the most part. And it's kind of a routine procedure. And so, Stefan, I think you are right on some level that they don't understand that there are techniques like roster billing where all they have to do is have a list of people and put the code down and they can submit a bill. They're simplified procedures for making it easier to do, but I think on a broad scale they're not doing it.
I don't have an answer to your why question, why it's not being done. It's the right thing to do, and it's good primary care, right? Good geriatrics care.
So
like all the other vaccines.
Yeah, and I think for a seasonal vaccine, which I think COVID will become, I think there's also some other lessons about how you go about it that might also make it easier. So you talked about roster billing, but there's also the prep you do ahead of the vaccine. And I know in Genesis, again, they did a lot of prepping for the clinics as they came in. to get people ready for the advent of this mass vaccination program. Karen, can you talk about what that prep looked like? You guys were teaching staff about how to figure out who to get lined up and how to do getting permission and so forth. I think you did a lot of work before those clinics actually began to make it run smoothly.
We did a lot of work to get consents ready for certain. Make sure that families were called or people who were giving their own consent had given it. That was all done.
Yeah.
In the run up to the clinic days, if that's what you're asking.
Yeah, and did you do that as written consent or was that done as a verbal consent?
Both, mostly verbal.
Yeah, and I think there's still places that are using written consent for flu vaccine, which is not required. I think this mistake about, how do you do consenting and how much work you can make trying to do it this way with written versus verbal, I think creates barriers to getting it done too. So how else do we mitigate complacency? That's sort of an open question, So we talk about mandates as being one strategy, and threat for losing your job for not getting it done. I thought about, the scarlet letter approach, where you identify so it's clear who didn't get vaccinated and isn't doing their job to protect the patients. That's not particularly a tasteful approach, but I think it would be effective.
You spoke about a care standard.
Uh-huh. So I like, so for the flu vaccines, I think one of the things that pushed vaccine acceptance among residents from the 40s and 50 percentile range 20 years ago to the 75 to 98% range more recently has been adding it as a quality standard so that it's reported. I think they have to have the same quality standard for staff, and that needs to go into the star rating or some other mechanism for when people choose where they're going to go. What do you guys think about that?
It's interesting, right? Pneumococcal vaccination was a quality measure. I can't remember exactly when, pre-pandemic.
Yeah, 2013, I think, and then in 2017 or so, I think it was demoted from a quality standard, if I'm not mistaken.
Yeah, so residents are relatively easy, their power of attorney, medical power of attorney, legally authorized representative, or themselves, if they have autonomy, are generally very accepting of the flu vaccine, and the rates are in the 80 to 85 range. And then we're deciles below that for staff. I think some of the ideas, Stefan, you talked about are, helpful. I wonder if some of the hesitancy we saw with the COVID-19 vaccine is going to translate to any vaccine we offer in the future, because people seem to be empowered about their own individual knowledge of vaccines and safety. I think we do need to re-educate the communities about the vast amount of information we have about how well flu vaccines work. And do they work 95%? No. But many years they're 50% or higher in terms of their ability to prevent disease. And so that's pretty good. And they're extremely safe. I mean, we have, decades of experience with their safety. So, I think that's a first step, at least in my opinion.
Yeah, I think about sort of just the process of how we introduce it, and then how we set expectations. and then how you systematize it so that you get some bandwagoning because everybody's getting it at the same time. And maybe if you started with staff, I think if you, for residents, again, I think it's easier than for staff, you can make it so that when they're initially admitted, even if it's not flu season, that you do consenting for all seasons coming up for flu. And now if they get admitted, for flu and for future doses for COVID vaccine, that you do it so that it's done and don't have to revisit it. I think that might be a strategic approach for the quality initiative. You don't know what you don't measure. I think that facilities need to make a habit of keeping track of it so that they could look at any given time what proportion are vaccinated. And so when new admissions come in, things like that, they don't forget that they're still supposed to be doing that, stuff like that. But to me, staff are the vexing problem, how to make that happen. And I think we've sort of prioritized patient-facing staff. But I think that undermines the message that this is an essential, healthcare, primary preventive approach, and that it should be all staff and not just patient-facing staff. I'm not sure that you do it under threat of firing, but I think you'd want to figure out how to make them feel equally relevant to the question about whether flu or COVID or whatever is introduced into facilities as the patient-facing staff are.
And Stefan, when you say that, is that sweeping to hospitals as well, all healthcare workers and all employees in a hospital building?
I don't know that you can be effective if you don't make it a universal requirement. Because what I worry, if I'm the small nursing home operator and I suddenly say everybody has to get vaccinated, I'm worried that all of those folks get siphoned off by a place that says you don't need to be vaccinated here. So if you have
I don't disagree with you. I don't disagree with you. But I'm only just making the comparison that if we're going to say not all clinical facing staff, patient facing staff in skilled facility, you would make the same argument for all non-patient facing staff in hospital or in outpatient practice.
Yeah, it seems to be that if we want to create an ambiguous message, we give different care standards, different approaches for different personnel. It's much easier to have a universal approach and say that's just how you do good care.
We spent a fair amount of time talking about that at Impact C with regard to the different types of staff and so forth. And we specifically talked about dietary staff and maintenance staff, particularly those that went into the rooms to, empty the waste basket and so forth. And even though, they're not really direct care staff, they could serve, as vectors for bringing flu into the building, as we thought about with COVID. And so, I think it's important to include all of them. It seems like the vaccination rates are higher among physicians, nurses in leadership roles, administration, and so forth. And it's the other staff, primarily the direct care staff, as you refer to, but also these other team members, if you will, that contribute to the low vaccination rates.
Yeah. Carolyn, do you have any final thoughts about what we've learned about COVID and infection control?
I don't know. I am impressed, actually. People want to learn about, they really do. People wanted to learn about the vaccine. They wanted to learn about the science that was happening around them, right? It actually became dinner table level conversation. That's pretty cool. And I do wonder what the impact is now on, I hope more people are going to want to go and become nurses to work in healthcare because they were inspired. Like maybe there's going to be like a great silver lining from this. Maybe we're going to raise more virologists. Maybe we're going to raise more geriatricians. Maybe the having public health infused into all of our lives for 2 years is going to have massive positive outcome. What do you think, Stefan?
Yeah, I'm going to give Ed a chance, and then I'll reflect on that a little bit.
No, I like that perspective, Carol, and I think, I know we have some junior epidemiologists in our office that didn't have that training before, but thinking big picture moving forward, I think, back in 2016, that foundational step where the CDC and CMS got together to kind of revamp infection control and antibiotic stewardship in nursing homes. And then, it culminated in 2019, I think, where they had to designate an infection preventionist, and they had to designate a pharmacy champion for antibiotic stewardship in each nursing home. I think that's going to help us moving forward, having that infrastructure. And I think it helped us with COVID, but I think it was a little immature. I mean, it still hadn't reached its potential. I think COVID brought it up a step, but I think we've got a lot of good stuff going on in nursing homes with regard to understanding infections now, public health information, how to track that, how to use it to help develop mitigation strategies. And I think this effort with the pharmacy partnership and nursing homes and
That's
CMS put us in a position where we might have the foundation for some systems that track information about vaccination status on a big scale that we could leverage for the future.
True.
Yeah, so I completely agree with all of those sentiments. And I think, so you talked about a little bit about what happens on the facility side and inspiring the healthcare workers themselves and the people who get to see those healthcare workers from home, changing that conversation and having more intelligent discussions. I think on the flip side of that, from a national policy and messaging perspective, we learned a lot about ways to create conflicting messages and things with the science changing on a daily basis, where we had to keep shifting our footing to say, well, that's not quite what we think anymore. We now want to do it this way. I think we were pretty clumsy as a country in figuring out how to do this in a way that didn't make people trust us. So whether it's the CDC or the White House or us providers on the front line, we were all trying to figure out also how to translate what those messages were, especially when they were mixed messages, into something where we weren't stepping on our own feet in the process. And I think we've gotten a lot better at that. When I think about sort of the approach to the booster campaign, you could see how different that was that time around than with the original vaccination. But even that had problems, so does that mean the vaccine didn't work, and stuff like that? So it added to hesitancy in one way and added to people wanting to get an extra shot in another way, sort of a mixed message of its own. So I think we have learned a lot from we talked about on the facility side, what generates the risk for these outbreaks in the first place, and how does that change things from antimicrobial stewardship, creating barriers, whether they're physical barriers or with ventilation. What happens with staffing? We didn't talk about the staffing shortages that were produced by COVID, sort of exacerbated. I know that still there's folks that are leaving nursing home work entirely because of the fatigue that they endured with this. So an ongoing problem. We talked about how to approach getting folks vaccinated and how to do the education for that. And then we sort of danced around sort of mitigating complacency and getting acceptance to better products and sort of figuring that out. A lot of ground we've covered. So I think that finishes our discussion. And before we open it up for Q&A, I want to give a heartfelt thanks to Sanity Pasteur for sponsoring this and putting us in a position where we can talk about doing care better, especially around the topic of vaccines and infection prevention. So let's go on to the Q&A session now. Great. So we'll take the questions directly from the chat. So the first one is, facility providers are for the residents, not for the staff. How to keep PHI separate from their employer? So this is about staff PHI.
Could you, Stefan? I'm not quite sure what the question is asking. Could you?
So my interpretation, and the person who asked this can type in again if they like, is the knowing which residents get vaccinated is pretty easy. That's part of doing the job. But as soon as we blur the line and start talking about keeping track of employee things that might by some be considered none of our business, how do we protect that and track it? I think there's a broader question that adds to this, and that is when employees move from place to place. And, in nursing homes, we have rapid staff turnover, and they leave one place because they didn't get vaccinated, and they go to the next place. What do they do to, if they make vaccination requirement, what do they go about to substantiate that? And when does that certificate actually run out, if they're starting to give boosters or revaccination and so forth? So there's a record system that our current typical EHR isn't designed to quite do all of those things. But does your administrator get to know who's vaccinated and who's not? And how do they keep that? We already do it for flu vaccine. And we're now doing it for COVID. So I think the employers actually know.
I think that question is not only applicable to skilled nursing, though. Human resource departments all over the country in the private sector are struggling with that question too. It's a great question.
Yeah. So that was a great way not to answer it. So we'll leave that as a vexing question. The next one is, my understanding is that COVID vaccination rates will be part of the value-based purchasing in the coming cycle. So I don't know if that's a final decision, but that was my understanding too. The next one is, COVID's impact is yet to be known, of course, but the early signs of exciting people about careers in public health, nursing, etc., seem to be reversing, with public health officials under literal attack and threatened physically, nurses quitting in droves, and generally disrespected, and worse, their advice ignored. How do you think we can recover from this?
Yeah, Caroline, I'm really looking forward to hearing your perspective on this. I'll give a few comments. I think it's on one hand, the public health community has received this enormous recognition that they hadn't received as formally as we had in the past routinely. On the other hand, the exposure that they got brought a great amount of criticism. But there's the extremes of that recognition are so diverse. I would say, those that were speaking publicly with regard to regulation and so forth were generally received more criticism than those at the state level. Like in our state of Virginia, we have long-term care COVID task force, and those public health officials that were helping us keep up to date with what was going on with the disease and procedures and getting tests and getting vaccine. They got a lot of respect for what they were doing.
Yeah, Carolyn, do you have thoughts on this?
Doesn't everybody? Right? Like, is it a glass half full, glass half empty question? Sort of. Yes, people are leaving in droves. They're exhausted, right? They're heroes, but the work is hard and they're tired. There's been no relief for 18 months. There's no clear end in sight. Who can blame them? Right?
Yeah, and with
But
short
at the same
staffing,
time, I mean, the medical students I interact with, they're still blooming with optimism and energy for healthcare. And don't you wish you could roll back the clock or tap them for it? Or Stefan, can you make a vaccine out of that? Right? Is
an
that what we
optimism
need?
vaccine, sure. Well, you know, so
I don't
think,
know. And yes, their advice is ignored, and that's not new to primary care either. How many people show up in a doctor's office and say, well, I read this on the internet, so it must be true.
yeah, so
It's
so
true. These things are true.
I think, you know, it is a pendulum of sorts. And I think Ed is right that there was this swing toward looking to public health. And then there was an undermining of the public health message and downright rejection of what the public health officials were saying in favor of political messages.
Mm-hmm.
And that undermining of trust. And there were a lot of things as the ranks in the public health sector started slimming. I think there were additional problems because the number of heads in the game to figure out how to message this properly and give enough advance warning and say, you know, the beauty and the hazard of science is that knowledge changes. And so anticipate changing messages as we figure this out. We didn't do a good job with that last year. You know, we sort of said, this is the way it is. And then as soon as somebody said something slightly different, just because the information was updated, it sounded like they didn't know what they were talking about the first time around, when in fact they were perfectly knowledgeable. And then I remember, you know, these White House press conferences where in the background people were wringing their hands because of what was being said at the front, trying to figure out how to be politically correct, but still get the science right. And it was an incredible dance to watch. And it severely undermined the idea of who do you listen to. It is interesting that, you know, before the vaccine, there was essentially no difference by how they voted in mortality until after vaccination. And then since then, there's been a huge disparity. There's a threefold greater risk of dying from COVID in states where vaccination rates were low. And that was defined by, you know, in that study, it was defined by which party they voted for. So the distrust of information and not understanding, you know, what the new things brought. So I'm with you, Carolyn, in terms of the bigger picture. I think that the distrust will get replaced. We'll renew this, and the value of what public health brought, and the, you know, ending of the pandemic will start changing things around. I think they have to be hearing the right messages long enough to, and consistently enough. And I think the muddiness of, you know, the murky stuff that happens with science when you're not quite sure and you're still figuring it out, that it will get easy enough that folks will be saying the same thing, because the pace of that evolution of science is going to start slowing down. We'll still get huge developments in vaccines and antivirals and so forth, but the approach to infection control and how we use these things, I think, will stabilize, and that'll make it a little easier. We have to just disentangle the science from the politics, that's all.
Oh, just that.
Just that. I mean,
Just
what
that.
else is there, right?
There's a practical piece here, though. Human society needs healers, right?
Yeah.
Public health is a segment of social healing, right? Of society's healers. So we have to make a comeback.
Yeah, that's true.
It's laughing.
What role do you see respiratory protection, N95s, and environmental controls like improving air exchanges in preventing infections and long-term care beyond the COVID-19 pandemics? Is this stuff here to stay? Anybody?
I don't know what to say about the N95 specifically, but I think masking has a potentially permanent role on the face of healthcare providers, but we'll see.
Yeah, Ed, I don't know if you have an opinion about this, but in my view, I think N95s are oversold. I think, just surgical masks seem to pretty much, as long as people were doing hand washing and all the other stuff, surgical masks seem to pretty much do the job. But it's not that N95s aren't better, it's just that the marginal additional benefit isn't that huge.
Yeah, I would agree, and they're more accessible, and I think that our response to influenza might be a little more robust as we see an outbreak start to develop with a few respiratory illness cases compared to how we've normally responded to outbreaks.
Right. When we put just regular masks on, including masks that we were reusing, as we hunkered down a year ago in March and April, flu and RSV essentially went away.
Mhm.
And we didn't have N95s. We were using surgical masks and cloth masks and all sorts of things just to try to do the basic stuff. So I think we learned some important lessons. So I think that will stay with us. Now, it begs other questions about, so if these not high quality masks, like regular surgical masks instead of N95s, can stop COVID, then what do we think about how exactly it's transmitted? Because those masks don't do a great job of keeping all those aerosols out. All right, so the last question is, as an educator, I love the approach all of you had about setting the standard at the beginning. Do you have suggestions on how to approach student populations about their responsibility to their patient population to be vaccinated and responsible about their own infection control approaches on and off the job? Ed, why don't you start?
So, it kind of comes back to, the public health message that we've kind of all talked about. And I assume the educator is a health educator and, educating people in a health related field. They have a responsibility with regard to having a lot of knowledge about vaccinations and hopefully understanding what vaccinations do to protect the public health and to accept them.
Carolyn?
It should be a standard. I don't know how it came to not be a standard, I guess is right. You're laughing, but yes, it is their responsibility to be a patient advocate and a public health advocate. And yes, I think we have to do a better job of teaching that in med school and nursing school and PA school and pharmacy school and all the schools.
I think the other thing we have to teach is where they get their information to know that they're teaching the right stuff.
Oh,
Because
everyone needs a lesson in that, Stefan.
right? So it's hard, so when we've seen people advocating, so I've been doing flu research for a long time, and it's been astonishing to me when I discover that my folks who are recruiting individual patients to be in a flu vaccine study themselves don't get the flu vaccine. That's no longer the case, but it used to be not an infrequent occurrence, this sort of hypocrisy of trying to figure out how to do it better. So, and in this COVID pandemic, we also saw this, where people were getting their information source was their best friend or some trusted person who really had no background to be able to assess the data out there. So figuring out, so that those people who become the authorities, those champions, that you can call them on it and say, well, I have this site that is our authoritative site. In theory, this could be the CDC or something like that, what they have published. then you'll get it right almost all the time because the CDC actually does a pretty good job. But they have to be a trusted resource, and we have to drill that into our students to do open book tests where they can look up the answers at the CDC website to answer the questions. So they develop the habit. Well, we are at the top of the hour, and I want to thank you both for suffering through this session, and the audience. These are great questions. These are exactly the kinds of things that we're struggling with every day. And Ed, from your pharmacoepi perspective, thank you for some of those insights. And all of us work in this industry. So Carolyn, you have a little bit of a corporate angle on this that's different than either of us. So I think it's really been wonderful to get these added perspectives. I see one last question, but we're at the top of the hour. I don't know if I'm allowed to go any longer. That's probably something Trish has to tell me. Trish isn't unmuting. It says, if COVID-19 is determined to be endemic, how do we shift messages about living with it, not counting cases, but worrying more about deaths, etc.? The public is still awaiting the end of COVID, which is not likely to occur. And I'll go ahead and just tackle that quickly. You guys can pitch in if there's something else you want to say. Yes, COVID-19 will become an endemic. I am 99.9% sure. I don't think it's just going to go away. And I think the vaccination approach will turn into a seasonal thing, maybe as soon as next year if we're lucky. And then I don't know if we're going to have it for 5 years or 10 years or 20 years, but I think we'll have a seasonal approach to this. The vaccination, I think, will become our mainstay. There are a bunch of antiviral therapeutics that are in various stages of trial. I think we'll have a second way to tackle it that might actually turn out to be pretty effective. And some of those have activity against other viruses at the same time. So I think our near-term challenge is not just learning how to live with it, but also how to think when you're seeing somebody automatically, instead of thinking COVID, to say it could be any of these respiratory infections, and then tackling it systematically in terms of your behaviors about how you deal with them collectively, in the way that you test, when you're talking about a long-term care setting. So you're not thinking monocentrically about COVID, but about flu and RSV and so forth. And then when you intervene, that you do all of your infection control practices, including, the not virus C. diff, because if you start empirically treating with antibiotics, you're going to get all sorts of other consequences if you don't get it right at the front end. So a lot of stuff to do. So any last comments from either of you?
No, thank you so much. Thank you to
everyone. Thanks, everybody. Thanks, Stefan, for your leadership and moderating this session.
Yeah, thank you guys. And thanks to our audience.